Okay, good afternoon, everybody. My name is Hayley Hurd and I'm the Programme Lead for the National Endoscopy Programme. And I'd just like to welcome you all today to the first NEP FIT learning event. It's really good that so many of you have been able to join us and that many others are going to be able to watch the event by looking at the pre-recordings at a later date. So just really like to thank our Clinical Pathways team for pulling together this afternoon's event. I'm sure you agree it looks like a really interesting agenda, and I'm grateful to all of the speakers and panel members that have been able to join us as well. So it is quite a busy agenda. We're going to try and keep to time if we can this afternoon. So if I could ask you to post any questions in the sidebar, please. And if you particularly think a question that's been raised is interesting, if I could ask you to like that, that will really help us prioritise the questions to put to the panel. We've got quite a lot of delegates expected this afternoon, so it'd be really helpful if you could do that, and we'll make sure that the most popular questions get aired in the panel. So I'm going to start by just giving a very brief overview of the National Endoscopy Programme, just to set the context for where the work on FIT sits within the National Endoscopy Programme, and then I'll hand over to other speakers to go through the detail. So I think it's, I'm sure you agree, there's lots of really good work going on around FIT at the moment, so it's good for us to be able to take a little bit of time out this afternoon to consider all that work. Okay, thank you, Adam. Next slide, please. So Welsh Government understood the challenges of endoscopy services a few years ago. They recognised that the challenges were historical. There were many concerns around waiting times and also around environment of some of our endoscopy services in Wales. So they established the National Endoscopy Programme back in 2019 to address these challenges with four main aims: to balance demand and capacity, to achieve JAG accreditation for our units, optimisation of the bowel screening programme, and implementation of the single cancer pathway. Thanks, Adam. And to enable us to deliver the programme aims, the structure was established like this, and I know many of you will be aware of this, but we started off with four subgroups reporting to a programme management group who report to our programme board, which is chaired by the Welsh Government. Next, please. I'm sorry if there's a delay. I'm in mid Wales and I'm not sure if our broadband speed is quite as good as it is elsewhere. But to cut a long story short, the Health, Social Care and Sports Committee inquiry into endoscopy services back in 2018 resulted in us developing an action plan to address their recommendations, which was printed in 2019, and it really formed the basis of the work that the National Endoscopy Programme was going to undertake over that 4-year period. And obviously that was written before anybody had ever heard of COVID, and our work plan has had to change as a result of the pandemic. Next, please. So in response to the pandemic, the National Endoscopy Programme pulled together a recovery plan that was not only going to enable us to recover from the pandemic, but also address the challenges that we'd got with the historical backlogs and environmental issues. And that resulted in many conversations within Welsh Government. But in October last year, Simon Dean, who was then the Deputy Chief Executive for NHS Wales, wrote out to Chief Executives from all of the health boards in Wales, asking them to develop implementation plans for the National Recovery Plan for Endoscopy, following four main principles. The first one was to make the very best use of what they've got. The second was to continue with their short-term increases in additional capacity, such as the waiting list initiatives and insourcing. The third point was for some of the health boards to develop permanent local additional capacity. So there are business cases with Welsh Government at the moment to develop new endoscopy units. And the fourth point would be to develop regional units. So the proposal had suggested that we develop 4 new regional endoscopy units to deliver endoscopy at scale. And this is the recovery plan that's currently being considered by chief execs and regional groups, and they're busy working up implementation plans. Next, please, Adam. So the National Endoscopy Programme has had to change the structure slightly to enable implementation of this plan so that we can support the health boards to implement it. So we still have the board structure chaired by the Deputy Chief Medical Officer and Deputy Chief Executive reporting directly into Welsh Government. We still have the Programme Management Group with the 4 subgroups, but we now also have a National Operational Delivery Group chaired by Paul Mears, who's our lead Chief Executive, and 3 regional operational delivery groups chaired by nominated individuals from the Regional Lead Health Board who feed into the National Operational Delivery Group. They're going to work very closely alongside the Programme Management Group and co-opt people in from the work streams whenever they need to. So slightly different structure, and this is a new and emerging structure. I think the regional groups have met twice, or they're certainly very new in their establishment, but this is the way that we're hoping it will work. Next slide, please. So as you see, we've got 4 work streams. A very important work stream for us is a clinical pathways subgroup. And that's a very busy work stream. And there are only 3 people delivering all of that work. So you'll hear from them all this afternoon. But Dana Knoyle is our managerial lead. Dana came to us from the Welsh Cancer Network, where she led the work on the single cancer pathway. And I don't think there's anybody in Wales that knows more about pathways than Dana. And Dr. Sunil Dolwani is our clinical lead, who you'll hear from later. And with Naomi Davis as project manager, they've been a real driving force in delivering the work of this subgroup. So just in terms of the high level actions from this subgroup that were published in the original action plan, they are all about optimisation, standardisation and equity. But we've highlighted that last point in red because that's particularly important. So our aim is to standardise pathways, but to standardise them according to evidence. Next slide, please. So the way in which the subgroup works is that they have representation from every health board and all relevant disciplines, so that we've got a wide group of people feeding into that subgroup. And then task and finish groups are established for individual pieces of work when there's a need. And one example of that work is the FIT task and finish group, which you will obviously hear a lot more about today. But there's some really good work gone on within that subgroup to develop the FIT framework so that we're able to support health boards implement it in a standardised way according to the evidence. So I hope that's helped in giving you just a general overview to set the context of where we are with FIT within the National Endoscopy Programme and the work that's going on within the team. Very happy to take questions at the panel later. But I think it's more important now that we hand over to Dana, who's going to talk to you about what's been achieved so far within this work stream of the National Endoscopy Programme. Thank you.
Good afternoon to everyone listening. I'm Dana Knoyle and I am the Clinical Pathways Subgroup Chair within the National Endoscopy Programme. I'm very briefly going to summarise what has been achieved across Wales so far in this area of work. But as you can see from our packed agenda, our teams today will be giving much more detail of the depth and breadth of work that has been undertaken in the symptomatic FIT arena over the last couple of years. So to briefly remind everyone, the use of FIT in the symptomatic population by primary care was recommended by NICE 5 years ago, and HDW supported its adoption in 2019. The clinical pathways section of the action plan asked us to support the implementation of DG30 across all health boards in Wales, and for us to agree and apply a common approach by the end of the programme's action plan. It also asked us to support an enhanced pilot of its use, which we will hear much more about very shortly. In this slide, If we look back at 2019, and Iron Bevan were the early adopters in Wales to roll out DG30. But otherwise, use in primary care was very limited. And as I previously mentioned, this is when the NEP was set up. Moving to 2020, we all know what happened then. The pandemic hit with a vengeance and endoscopy services ground to a halt. As you can see here, during the summer, health boards quickly began to use FIT as a triage tool in suspected cancer referrals. BCU also gave access to primary care at this time. It was also very clear to the National Endoscopy Programme that we needed to expedite the development of the FIT framework to support health boards in doing this. And as we can see in this slide, from the broad membership of the Task and Finish group at that time, we are really grateful that despite the challenges and pressures of the pandemic, teams across Wales still managed to progress this work. The framework can be found on our website. I put the link below. It provides guidance for the implementation of FIT, as well as the evidence base for its approach. It provides practical applications such as patient, GP, and secondary care information leaflets. It also has some quick guides, understanding that healthcare professionals are busy and need quick guidance tools when patient facing. So back to our timeline. As I mentioned in the framework, it was published in spring 2021. At the same time, we can see Cardiff and Vale commenced their pilot, rolling it FIT out across primary care. Cwm Taf Morgannwg also rolled out to primary care in that summer. And from this table, you can see that Powys partially roll out. We will hear from them today about the unique challenges that they face that explain why it was captured as partially at that time. And here is our current position. Swansea Bay have recently rolled out, and we envisage Hywel Dda will be very soon. So to summarise, I feel that much has been achieved over the last few years during a very challenging time. We have almost implemented symptomatic FIT across the two pathways in Wales and developed the framework that supports a common approach. Cardiff and Vale have also undertaken their pilot. And we will hear and share in much more detail and learning through this afternoon's event about this and the other great work undertaken by teams in Wales all through a pandemic. Thank you very much.
Thank you, Dana, for a really interesting talk, and really good to see just how much good work's been going on. So if we could save any questions for Dana for the panel a little bit later on this afternoon. And we'll move straight on to next presentation, which is a double act from Dr. Ramaraj, who's a consultant gastroenterologist in Cardiff and Vale and leading the work on the FIT pilot, and Dr. Rachel Lee, who is a GP and assistant medical director, who has also been very instrumental in the Cardiff and Vale FIT pilot. So it's a piece of work that we've been very excited about within the National Endoscopy Programme, and looking forward to hearing the progress this afternoon. Thank you.
Thank you for inviting me and Rachel to speak on the results of the symptomatic FIT pilot, Cardiff and Vale. So the aim of the pilot was to aid primary care triage pathways in the DG30 or low risk eligible cohort, as well as observe the effect of FIT on the NG12 cohort. It was also to observe the effect of the integration of the FAST score with the FIT value to identify high and low risk groups. It was a collaborative intervention between primary and secondary care, and the results of the pilot, after full evaluation, aims to inform future practice. The outline of my talk will go through the operational aspects prior to the commencement of the pilot, so the setup, interim results, and learning and next steps. So this was the operational pathway where the patients who are present with lower GI symptoms would be assessed by a primary care physician, and eligible patients would then be referred for a FIT test via the web-based online request, which was designed by us. The patients who fulfilled DG30 criteria or low-risk criteria, the primary care physician would wait for the results before referring through to secondary care if it was FIT positive. And for the NG12 group, we advised to complete the online form alongside referral to secondary care. Once the FIT requests were requested online, this then went to Public Health Wales, and within a day of receiving the request, the kits were then sent out to the patient on the same day by first-class Royal Mail. Once the FIT test was returned back, analysis of the FIT results took place within 48 hours. The results of this were then pushed through to Welsh Clinical Portal and GP links, and then also emailed to a dedicated email, generic email, which the FIT coordinator then tracked the results on. And then depending on the results, primary care would either refer via the electronic system to secondary care. So going right to the start as to how the design of the kits and information leaflets that were provided, we felt that it was quite important to provide a detailed information leaflet in order to not just inform the patient, but also help in the uptake of the FIT test so that they understood the need for having the FIT test. So this also included a QR code as well as a video link, which we thought would help patients to understand the need for the test and how the test was done. This was the online link for primary and secondary care. So this included demographic detail, but also included symptoms, relevant symptoms, as well as medications such as anticoagulants, being on aspirin or being on NSAIDs. And really the key takeaways from this were as to the reason as to why we set up the online link was to get data visibility at a centralized point to ensure standardization and improvement and optimization of pathways through audits with availability of this information. So the pathways in primary care for the low risk group was pretty straightforward. Because if they were FIT positive, they would be referred straight through to secondary care. But if they were FIT negative, there was a pathway that was designed whereby information on health pathways would help to inform further investigations and referral to secondary care if needed. The pathways in secondary care were agreed by key stakeholders in gastroenterology, colorectal surgery, and radiology colleagues, whereby we had decided that in patients who were over 60 with a change in bowel habit, we would wait for the FIT test to come back before triaging them for further investigations. So if they were FIT positive, straight to test. If they were FIT negative, then we would either downgrade the referral or see them in clinic or ensure safety netting with a detailed letter to primary care. I will hand over to Rachel to discuss about the implementation and dissemination of information in primary care.
Thanks, Raji. So from the primary care perspective, it was really important that we got the message out and communicated about this symptomatic FIT pilot, so everyone understood what it was about and how to refer. Initially, we discussed the proposal at the LMC meeting. So we had two meetings. One was right at the very start to give them the heads up that this was coming. And then the second meeting, we went back with far more information and explained the pilot in more detail. We also presented at the CD Forum, which is our GP lead meeting, and that included all the GP cluster leads. And again, from both the LMC and the CD Forum, we had a very positive response, and they were keen to help us promote it. I then got a briefing document with all the key information together with Raji's help, which we emailed to all primary care clinicians. And this was again to make sure it was easy for them to know how to access the online form and again to understand the pilot. The LMC put the information in their newsletter, which is really helpful. And then we did a webinar education session for primary care. And this was linked on the Cardiff and Vale portal, so it was accessible by people after the event. As Raji said, we integrated our symptomatic fit pathway into health pathways, which is the go-to place for GPs to use when they're unsure about pathways and what to do. So symptomatic fit was an integral part of that. And what I found was a really important part of this is I gave my email address for any concerns or issues. So again, GPs had somewhere they could go if they were unsure what to do. Thank you.
So the FIT pilot was a NEP funded project. It went, after all the processes were put in place, it went live on the 22nd of February 2021. Currently, it is still continuing till full data evaluation and analysis is available to implement in the service. Today's talk includes 12-month data set. So the total kits that were disseminated in this period were about 7,615, of which, interestingly, 119 were out of area. Completed data sets with clinical outcomes were done in 1,531. So data validation is currently ongoing. So I'd like to now talk through the interim results. So this is the trend of the total referrals, both from the DG30 and NG12 group. And the orange bits are the referrals from secondary care, and the blue bits are the referrals from primary care. So as you can see, towards the start of the project, there was a slow uptake from primary care. And then you can see that quickly primary care started to request more tests. And I think this took time to embed. It took about 3 to 4 months to actually gain momentum, particularly in the NG12 group. And I'll show you a slide following this, which demonstrates this. But the key role was the coordinator's role in all of this, where when GPs did not request a FIT test, and if secondary care requested on their behalf, then a feedback letter, a positive feedback letter went across, which explained the pilot with links, with the relevant links to the educational link, the online link, and health pathways link. And in the first 5 months, around 800 letters were sent by our coordinator. And this excludes the emails that were sent as well to GPs. In addition to that, from secondary care, when we got electronic referrals, we would reply back to GPs with e-advice and also spread the word through the electronic system to say, hey, did you know that this is available? These are the online links. So please use it in the future. So I think that really helped to embed this in the request. So this is the low risk group and the high risk group. As you can see, there was a significant confidence in requesting the FIT test for the DG30 group, so quick pickup by GPs. Whereas for the NG12 group, it did take some time. And as I mentioned before, it took close to 3 to 4 months. So this is the FIT test request per GP cluster, and the return rate was about 82%. So an average of 18% was not returned. And this over here, you can see roughly the average out, but you can see in some clusters, this cluster, which is Cardiff North, is obviously quite a large, it's the biggest cluster in Wales, so you would expect that the significant amount of tests were requested. But some clusters, which were about 23%, 22%, seem to correlate with deprivation, but also in this group in Cardiff City South, which was a working population, again, it was about 22%. Difficult to make any interpretation from this, but it is an observation. Now, these are the tests, the FIT test results. So 7,615 tests sent out. We excluded the kits that were sent out of area and duplicates. And also we had a significant proportion which were not returned and some that were rejected. Ultimately, we had 5,753 patients, of which around 18% were FIT positive and 82% were FIT negative. Now, if you dig deeper into whether they were low risk or high risk, you had a third of them in the low risk group who were FIT positive and 67% in the high risk group that were positive. Whereas in the FIT negative group, you had 45% who were low risk and 55% that were high risk. We have completed outcomes, clinical outcomes in 1,531 patients. So when you look into the FIT results and the detection of cancer in this group, you can see that in the low risk group, there were 17 cancers detected, i.e. 5.7%, whereas in the high risk group, there were 79 cancers out of 588 that were detected, which is 13.4%. And overall, in the FIT positive group, the cancer detection was 10.8%. Whereas in the FIT negative group, mainly in the high risk NG12 group, there were 7 FIT negative cancers that were detected, which is about 1.1%. What's interesting here is the circled columns are the NG12 high risk FIT negative group. So in this group, it was not just obviously colorectal cancer that was detected, but a proportion of patients, about 38%, had benign findings, which included polyps, inflammatory bowel disease, diverticular disease, and then of that, 13% were polyps that were detected. So I'd like to talk about the FIT negative cancers that were detected. And now this, apologies for the busy slide here, but this gives detail of the FIT negative cancers that were found. You can see the FIT values quite low there, but what really the takeaway from this really is that all of these patients were over 60 with an average age of 75. When we used the FAST score into this cohort, all of them were high risk. So the FAST score uses the fecal hemoglobin, age, and gender. And if the score is above 2.12, this indicates a high risk for colorectal cancer. And interestingly, all the FIT negative patients in this group had a FAST score more than 2.12. Majority of these patients had a change in bowel habit with weight loss, so they would have been investigated anyway, regardless of their FIT result. 2 out of 7 patients had iron deficiency anemia, so again, they would have gone straight to test. 2 out of 7 patients presented acutely following their FIT test with large bowel obstruction. And of the cancers that were detected, 4 of them were proximal colorectal cancers, of which 1 was a serrated polyposis syndrome patient, and 3 out of 7 distal colorectal cancers were all rectal cancers. So when we looked at FAST score in the DG30 and NG12 group, whether they're FIT positive or negative, no surprise there. If they're FIT positive, then the FAST score would be more than 2.12. But in the negative group, you had about 69%, particularly in the NG12 group, 69% of them who had a FAST score more than 2.12. So it would be really interesting to know the complete outcomes of this group. We already know that 7 FIT negative cancers were found in this group, so it'd be interesting to see what the full data evaluation is in this group. This may indicate, if we were to use the FAST score, it may indicate more colonoscopies, but equally it may indicate more detection of cancers. And then when you use the FIT with, so this slide basically shows that if you were to integrate the FAST score, you would detect 100% of colorectal cancers in this cohort of what we've analyzed. But interestingly, you'd also find more polyps in this group. Now, this is preliminary data which has looked at the investigations that were used following a FIT test. So in the FIT negative NG12 group, so there were 605 of them prior to the FIT test. All 605 would have had a colonoscopy, but in this cohort, 23% to around 24% underwent a colonoscopy. So potentially around 400 colonoscopies have been saved. But again, this is preliminary data, and we would need to have the full data evaluation in order to come to this conclusion. So a word on rectal bleeding. Now, there has been, I would say, a low confidence in using FIT in rectal bleeding. And just looking at this cohort, so this is rectal bleeding without any other GI symptoms. So in this particular group, there were 371 patients, of which only 25% of them were FIT positive, of which there were 7 cancers detected. But in the 75% of the FIT negative patients, there were no cancers detected. Majority of them were not on antiplatelets or anticoagulants, and in fact, they were not on NSAIDs either. So when you looked at the final clinical outcome in patients who had rectal bleeding, you could see that majority of the FIT negative patients had benign findings, i.e. diverticular disease, hemorrhoids, and polyps. About 49 out of 357 patients underwent a colonoscopy despite being FIT negative, and all of them had benign findings. So about 24 patients underwent a flexible sigmoidoscopy and then a colonoscopy. Of this, 10 patients were FIT positive, noted when they attended for flexible sigmoidoscopy. So potentially it could have been this flexible sigmoidoscopy could have been avoided in this group. It's probably safe to conclude that FIT can be safely used in rectal bleeding consistent with the evidence out there. If they're FIT negative, then doing a flexible sigmoidoscopy is probably reasonable unless they have added other GI symptoms. So the conclusions from the interim data analysis indicates that there was a successful implementation of FIT in both the NG12 and DG30 group with expected outcomes. It was a successful collaboration with primary care. The role of the coordinator and nurse is quite key for success. FAST score seems to be useful in detecting FIT negative cancers. Tighter triaging may help to optimize resources. FIT can be probably used in rectal bleeding safely. So I think the learning lessons are recognizing the key role of the coordinator and FIT nurse. Juliet, our coordinator, was key in tracking results and communicating with GPs and secondary care for positive FIT results. Also, we brought in Tina, who was our nurse, a FIT nurse, who mainly did triaging for colorectal, but also for some patients in gastro. But it was quite, she was quite key as being the point of contact for patients and also following up with those FIT results. We also probably need to think about when kits were not returned, rather than one of the things that kept happening and still is when the kits were not returned within that 2-week period, the clinician would automatically request a FIT test on the portal. And rather than do that and waste resources, it may actually help for direct communication to happen either through the coordinator or the nurse rather than reissue kits. The audit trail regarding FIT positive patients who were DG30 and not referred to secondary care would be helpful for primary care to communicate the outcomes for these patients because the coordinator would usually write to the GPs when the FIT tests were positive in the DG30 group, where that group is primarily managed in primary care, and just knowing that conversation that the GPs had with the patient, whether they'd want to go through with the test or not, would be helpful. So developing that audit trail would be quite useful. I do think after doing this for over a year that it's an enormous task to validate clinical and clinical information and data, and I do think it does need a full-time person in this role. When I say it, full-time person, coordinator and FIT nurse, because it is an enormous job to track outcomes due to the complexity of how these patients are referred through. Developing tighter triaging to optimize resources in primary and secondary care is also key, and also trying to develop the confidence in using FIT in rectal bleeding, and the recognition for the need to develop FIT clinics. Tina, who's doing the FIT nurse role, has not evolved to doing clinics yet, but that is what we are thinking about in the future. So the future considerations are, obviously, as I said, validation and data collation is underway, and it would be really useful to know what the outcomes of all FIT negative NG12 patients, to look at the outcomes of all downgraded referrals, to look at inappropriate referrals and FIT requests, particularly in the elderly age group. We've had close to 30 referrals with patients who are between the ages of 90 to 102. And also some referrals with very poor performance status. So looking at those would be quite helpful. Once the analysis and service evaluation is taken place, then we would be ready to do a business case. It is already in our IMTP at the moment. How I think the future will look like? Well, ideally, I think GPs should be able to request at the point of contact, which they're already doing, but also refer with the results. And I hope that guidelines that support the use of NG12 in the future would encourage the use in the high-risk group. FIT nurse clinics, as I alluded to before, should run similar to the bowel screening clinics. So screening practitioners run similar clinics, and I wonder case selection for this group should probably be the FIT negative high-risk group, the people of over 80s who are comorbid or uncertain cases. I wonder whether FIT coordinators should be able to request tests, validate and send reminders, particularly text messages that might help uptake. So I will hand over to Rachel to talk about the feedback from primary care.
Thanks, Raji. So I think the overwhelming feedback from primary care was very positive. It was very well received, and I think having the access to Symptomatic FIT as a diagnostic tool was really helpful. I think the main concerns were minor ones, and it was really about the online form. It was quite lengthy to complete, not necessarily the clinical information side, that was quick. The main issues raised were the fact that it wasn't self-populated with the patient's details, and in an already busy surgery, that extra minute and a half it took to fill in the patient's address and things just added to the time taken for this. The biggest gripe was the robot section. So this was where you had to tick to show you went to robots. And I think initially GPs got stuck, sometimes having to tick that several times before it was allowed to go through. However, that seems to have improved recently. There was also a concern in that the FIT test results didn't automatically come through in the GP results links. And that could be quite significant because the result wouldn't necessarily have been seen by the GP and it wouldn't sit in the actual notes. So again, there was a quick IT fix for that, which we rapidly circulated around, but an active change had to be made in each GP system to enable it to be visible in the patient's notes. And I think the main concerns that we had were raised about those that were sent on an NG12 pathway but were downgraded with a negative symptomatic FIT. And I think that perhaps could have been remedied by perhaps better communication initially for the GPs to understand what was happening, but also perhaps from the behalf of the GPs. I think sometimes our referrals could have given more information to allow clearer triage to be made. But again, I think that has been remedied, and much clearer information is now sent back to GPs if a patient is downgraded with clear safety netting attached. Thanks. Back to you, Raji, for secondary care.
Thank you, Rachel. So in secondary care, I think this was well received, and there was constructive feedback provided through the pilot through direct contact and governance meetings. So we were able to troubleshoot and address concerns right from the start and throughout the pilot. There was a concern about FIT negative high risk patients, particularly in the initial months, where there was slight variation in the way that the FIT negative group was discharged back to primary care, as Rachel alluded to. So that was thereafter resolved within a few months, and hopefully the audit, hopefully our evaluation will also show that there was a reduction in variation once the full evaluation happens. But there was also a concern about radiology requests. So once the pilot started, so primary care couldn't request for CT scans when they were on a USC pathway. It was rejected by radiology, but there was reasons for that because when GPs request radiology requests, unless they put down USC on the form, radiology don't triage it because they don't have an electronic system currently. So those are issues were ironed out where we specified a ring-fenced a few indications where GPs could actually request it rather than wasting time by sending back and forth to secondary care. So that was ironed out around 6 months into the pilot. And then obviously rectal bleeding, there was an initial hesitation to wait for the FIT results. I mean, to be fair, we did, as per the pathway, we did indicate that we shouldn't wait for the FIT results to come back before you know, triaging straight to test. But as time went on, I think confidence in this has increased. And I have already spoken about FIT negative cancers where there was anxiety related to whether we were missing cancers, but clearly preliminary data seems reassuring. I'll hand over to Rachel now to talk about outcomes of downgraded patients.
Yeah, thanks, Raji. So this was just a spot check again. It would be very time consuming to do an audit of all of these, but this was looking at one surgery with nearly 9,000 patients. And for that surgery, during the course of the pilot, 15 of the NG12 referrals were downgraded as a symptomatic FIT was negative. So I looked at all of these patients and we found that there were no cancers diagnosed in this group to date. The diagnoses are listed. So we had a wide range. We had diverticular disease, melanosis coli, a dietary iron deficiency and folate deficiency. Campylobacter was one of the diagnoses. Constipation was one. Colonic polyps, and one was systemic sclerosis. Actually, that diagnosis was found following that referral. 2 went on to have colonoscopies routinely. 1 has actually come back to us and has requested a private referral for a colonoscopy, although have no red flag symptoms at point of that referral. And 1 gastroscopy was done as a routine. And then just to add to that, just out of interest, I did again look at 3 of the DG30 patients who had positive FIT tests but who had not been referred to secondary care. And all 3 of those actually were very elderly and declined to have further investigation. So again, with the point Raji made earlier, I think in primary care we perhaps need to consider the value-based healthcare approach to this and perhaps look at the patients before we do these tests to make sure it would be appropriate for further investigations should they be positive. Thank you.
Thank you to everyone for taking the time out to listen to our talk. I'd like to acknowledge a lot of people who helped in the success of this pilot. I'd like to thank all my colleagues in gastroenterology and colorectal surgery. A special thanks to the National Endoscopy Programme, without whose funding this pilot would not have been possible. Public Health Wales, Hugh Rogers, Gareth Powell, David Evans. We spent many hours and weeks trying to put the kits and information leaflets out and the online links. In fact, prior to COVID, discussions were happening over a year's period where we were trying to put things together, and then obviously COVID messed things up, and then we had to then change the online link. So their help has been invaluable. Gastroenterology Directorate and our CD, Dr. Claire Tibbetts, and Directorate team, Dr. Kate Baker and Lisa Palmer from Primary Care. And obviously, last but not least, pilot would never have been successful without our core FIT team. So a big shout out to Rachel, Sunil, James, Ruth, Tina, Juliet, and Marie. Thanks a lot.
Thanks very much, Raji and Rachel, for a really excellent presentation. Our next speaker probably needs no introduction, but you've just seen his picture. So Dr. Sunil Dolwani is the clinical lead for the Clinical Pathways workstream of the National Endoscopy Programme and has been the driving force behind FIT, and will talk to us this afternoon around fit for purpose with clinical oversight. Thank you.
Good afternoon, and I hope you've enjoyed the interesting talks in the meeting thus far. I'm going to try and put some clinical oversight on what we can interpret from FIT. So let's launch into that. As you would have seen from what we heard before, nice guidelines came out a while ago now on how we use FIT in the routine or low risk pathway. Before we launch further into high risk, it's perhaps worth just spending a few seconds on what we call a 2-week wait or a USC referral as per NICE definition. If you look at this, and we're all, I'm sure, familiar with this, we refer people for a suspected cancer pathway referral if they're 40 or over with weight loss, abdominal pain, 50 or over with rectal bleeding, or 60 or over with the things that we consider alarm symptoms, again, iron deficiency anemia, change in bowel habit, or occult blood in their feces. And this should also be considered if you feel a mass, rectal or abdominal mass, and people with rectal bleeding, along with any of the other alarm symptoms that we've discussed. This is useful to consider as to what is the conventional referral stream that we follow when we look at comparison of this. Now, as you've heard from Dana's talk, we disseminated the National Endoscopy Programme framework for implementation of FIT in the symptomatic service just over a year ago. And we discussed a lot of the evidence around FIT at the time. So if we look at one aspect of it, which is in the high-risk pathway or in the NG12 stream, which is the symptoms that we just saw just a few minutes ago, FIT, we know it can be used as a COVID mitigation strategy, and many people have done so in their trusts and health boards. But can we use it to assist with our prioritization process? And this was our guidance at the time. What you'll notice, apart from what we know already in the left-hand side here, is the situation with rectal bleeding, which we at the time felt could be discretionary because there was still evidence emerging around how confident we can feel using FIT in rectal bleeding. And we can discuss some of this now, as I think there's a bit more evidence available than there was at the time. So in primary care, where would the use of FIT be helpful? If we look at low-risk GI symptoms, then clearly there is nice guidance there. There is no controversy. What about as part of a comprehensive clinical assessment and triage in high-risk symptoms and in rectal bleeding? So let's look at some data here from a relatively recent meta-analysis of a number of studies and try and understand some of this in a bit more detail. If we did what we have always done in terms of NICE NG12 and use symptoms alone for our triage, then these are the numbers needed to scope to detect one colorectal cancer if we just do that. So you'd be doing 30 colonoscopies or over 50 colonoscopies or over 30, again, depending on which cohort you're looking at, to detect a single colorectal cancer. By using FIT at the threshold of 10 or more, you need to do only 6 colonoscopies to detect a single colorectal cancer. Surely a far more efficient way to detect colorectal cancers without using more colonoscopies that do not yield any significant pathology. Another really important thing to understand here are these 2 columns. So what about, there was a lot of debate about, based on some of the studies, particularly the D'Souza one, about why don't we drop the threshold down and drop it to 4 or even lower limit of detection. Now, whilst we may have less false negatives by doing that, we will get quite a few more false positives, which means that to detect a single colorectal cancer, if you drop the threshold really low, you're going to end up doing an enormous number of colonoscopies. And the false negative rate essentially is telling us that this is not the best thing since sliced bread. If you use FIT alone, then there will be a proportion of colorectal cancers that will get missed just with the threshold that we're talking about here. So it's important that we understand the value of FIT here. The numbers needed to scope become much more achievable. The false negative rates need to be borne in mind when we're talking of using FIT alone or with other parameters, as we'll discuss. And the take home is, bear in mind increase in false positives as we drop the threshold as well. So we also need to think about now the limitations of FIT. FIT is a poor predictor of non-cancer pathology like inflammatory bowel disease, advanced polyps. If you look at the positive and negative predictive values there at a FIT threshold of 10 or more, you can see that they're not as good as what we've got with cancer. And significant bowel disease, which includes variable mix of pathologies here of diverticular disease, angiodysplasias, polyps, inflammatory bowel disease, etc. So the interpretation of this for us should be, if the clinical setting suggests that there may be a possibility of IBD or something similar, then you may require further investigations and not just rely on FIT alone. Here's an example. When we look at numbers, it doesn't quite sit so well, but this is a case from my own list. 65-year-old male, builder, fit and well, had some change in bowel habit, more towards diarrhea, intermittent rectal bleeding, no other alarm symptoms, no weight loss, fit of just 0.5 micrograms of hemoglobin per gram of feces. Blood tests were all unremarkable. You can see this quite a sizable advanced polyp in the upper rectum, and 2 other polyps that were found that were also left-sided. This is a good example of where FIT is a poor predictor, but you would still have significant bowel pathology. So this brings us to the concept which we try to articulate in our FIT framework as well, the concept of trade-offs. This is not a black and white situation when we're discussing FIT. We're trying to balance individual risk and that false negative with the likelihood of having colorectal cancer, with the stress and the capacity in the healthcare system. So lowering the FIT threshold below 10, as we said, translates to increase in false positives and higher numbers needed to scope. So could part of the future solution include risk stratification tools? Now, I know the Delphi document that Kevin and colleagues have been looking at from the BSG ACP point of view has suggested there is not a clear picture around that, but I'll take you back to the slides that Raji presented from the Cardiff and Vale FIT pilot. You will notice here that all the FIT negative colorectal cancers, the 7 in the 1500 odd that were analyzed, all of them had a FAST score above 2.12. So none of them would have been missed had we used the FAST score instead of using, if we analyzed by FAST score instead of FIT alone. And you've got the breakdown here. If you've got weight loss, iron deficiency anemia, acute large bowel obstructions, that they would have had abdominal pain. And this brings us back to the same question. If we use our clinical interpretation and clinical oversight alongside FIT, then this would not have been controversial in any way. So we did use FIT, but if you look at the spectrum of symptoms that these people have got, you would see that abdominal pain, iron deficiency anemia are settings where you can get a false negative FIT as well, but the FAST score seems to overcome it in this small cohort. This is another way of looking at it, though, in that if we had used the FAST score instead of FIT alone, the so-called negatives and positives here, the FAST score would have categorized more people as high risk, so more people would have had colonoscopy. So not missing those cancers essentially comes at a price of doing more colonoscopy. Not as much as if we weren't using FIT at all, but still more than if we were using FIT alone. So the FAST score comes at a price of some more colonoscopies. Again, there's a trade-off. And this is a concept we need to understand. It's not either yes or no. It is, if you want a lower threshold, you're going to need far more colonoscopies if you don't want to miss those few cancers. If you want to use risk scoring, it will also miss far fewer cancers, but you will need to have some more colonoscopies. So using FIT alone, as we saw in that false negative column at the end in the slide before, will miss 10 to 12% of colorectal cancers. But if we use a combination of FIT and symptoms, by which I mean clinical oversight, risk scoring, then we may minimize these missed cancers. Although I think most of us would accept there's more research required on risk scoring systems. Now, these are very simple ones. The ones that we used in the Cardiff and Vale pilot, the FAST score, just uses age and gender. There are other more complex risk stratification systems, including some blood tests, including hemoglobin, including awareness of settings. A lot of these don't perform particularly significantly better than clinical oversight alongside FIT or simple FAST scoring alongside FIT from what we've got thus far. Though admittedly, this is a limited set and we are still completing our analysis. So all of these further minimize false negatives and reduce the proportion of missed cancers. I want to spend a little bit of time now talking about the concept of safety netting. Now, what does this mean to people? We want, as we've discussed, to reduce these false negatives, but at the same time, we want to track patient compliance with sending stool samples back. That is also safety netting. So we need the mechanism for reminders to patients. We need consistency in the management of these so-called FIT negative referrals, the USC ones, agreement on what downgrading will mean versus alternative investigations. And a concept for us to really understand is that downgrading does not mean it's a closed door. It means perhaps we can consider alternative management strategies or investigation pathways. And that may exclude significant pathology. These could be CT colonography, colon capsule, reviewing the patient in clinic, reviewing back with the primary care, and mechanisms to re-refer if there are persistent symptoms or concern in a timely manner. All of this is part of safety netting, and I cannot stress enough how important tracking is in this. So as a schematic, if you've got a 2-week wait or USC referral, what could be your possibilities if the FIT is supposedly negative or less than 10 micrograms per gram of feces? Well, there are various options here. Could opt for just downgrading to a routine instead of urgent or USC colonoscopy. If it's rectal bleeding, a flexible sigmoidoscopy, and we'll talk about rectal bleeding in a moment, as a lot of the pathology found here would be accessible with a flexible sigmoidoscope. CT colonography, particularly if you're suspecting extraduminal pathology, or if there's uncertainty, if there's abdominal pain, where you know it might be a false negative as well. Colon capsule, which is under evaluation at the moment, and certainly 4 health boards in Wales will be starting the Bevan exemplar innovation pilot on this very shortly, which is another option available for people where you're suspecting mucosal pathology, maybe inflammation, that might help. Or you might opt for a clinic review. You could opt for a repeat fit after an interval, but this is of really questionable value. There isn't much evidence to support that. And you can see there is a suite of options there, even if there is a negative fit test where you can investigate the patient safely rather than it seeming like a closed door. Here's another example, again from my list. This is a 63-year-old male, altered bowel habit, intermittent rectal bleeding, referred for a flexible sigmoidoscopy. The fit was done, but the result arrived later. Now, the interesting thing here is the first fit value was 438, quite high. Now, this patient, of course, subsequently went on to have a colonoscopy, and that's what we found in the rectum. But for some reason, this patient also had a repeat fit test, which was done 2 weeks later before the polyp was removed, which was 8 micrograms per gram. So below the referral threshold or below the colonoscopy threshold. So this is interesting. The polyp was still in situ, but we have a very widely variable fit result here, and I'm not quite sure why this was. So we had to remove this huge polyp with ESD here. It just illustrates the point we were making in the previous slide, the questionable value of early repeat fit, and that there might be some variation, some other factors we don't quite understand yet, and which needs more research. Other issues for consideration, well, are we using fit appropriately? Are we interpreting it right? Are we really focusing too much on pathway metrics rather than outcomes? So by this, I mean the time from a request, sample collection, if the patient's a bit delayed a couple of days in sending the sample back, sample being received in the lab, getting the result back. And our labs, as you will hear in the presentations further on, have been absolutely superb in turning around sample times really very quickly. But if there is let's say a lag of 2, 3, 4, 5, 6 days, quite honestly, there is now significant evidence that that does not make a difference to outcomes, and it is far better for us to chase the sample collection with the patient rather than worrying about the pathway time for those few days, because that really is not going to make a difference to outcomes. We'll talk a bit about rectal bleeding and non-specific symptoms. How about appropriateness of referral? I'll leave you to read this briefly, which says, essentially someone, elderly lady, epigastric discomfort, reflux, taking PPI. Despite this, has developed epigastric pain and reflux, arrange an OGD, all perfectly fine. What I cannot quite get my head around is that sentence, I've requested a fit test and requested up-to-date blood test. I'm not sure that this would be real utility of a fit test here. It is appropriate referral to secondary care, but perhaps not the most appropriate role or use of fit. What about rectal bleeding? Now, you've seen some interesting data from Raj's slides, and there's a lot of data that has emerged from the larger cohorts. Rectal bleeding alone or rectal bleeding in combination with other low GI symptoms. And there have been studies that looked at all symptoms, including rectal bleeding, and specifically investigated the added value of fit. The consistent findings seem to be that the proportion of those who are fit positive is higher in those with rectal bleeding. Of course, you might say that's an obvious no-brainer, but the proportion of cancers is also higher in those who are fit positive with rectal bleeding. And most, but not all, fit negative cancers, so to speak, in those with rectal bleeding were in the left colon, so within reach of a flexible sigmoidoscopy. This is quite an interesting observation. The practical implications of this essentially suggest that if you request a fit test in someone with rectal bleeding and refer for a flexible sigmoidoscopy, as you would otherwise, if that fit test turns out to be above the threshold, it can be upgraded to a colonoscopy instead. If it is negative, the flexible sigmoidoscopy should be able to catch most, perhaps not all, but most of those false negative cancers in the left colon. Depending on the findings at flexible sigmoidoscopy, they may or may not, of course, need further investigations if they have some polyps there as well. And this is just a copy of Raji's slide that you saw, which illustrates that point. In that very small cohort, there were no fit negative cancers in the rectal bleed cohort. But again, I would stress this is a very small preliminary analysis at present. What about anemia and fit? Again, this is a setting where fit can be false negative, and that has been fairly consistent across a couple of larger studies. And the most practical advice here would be go to the BSG guidelines for iron deficiency anemia, request FIT, but also refer for investigation of iron deficiency anemia. FIT may still be helpful for triage. You may decide whether you want to do an upper investigation first or lower based on that. But that should not be the deciding factor, as we saw in our cases that had false negative FIT in the Cardiff and Vale pilot as well. So clinician input is really crucial in deciding, does this patient have luminal symptoms? Is extracolonic pathology a possibility? What about rectal bleeding, iron deficiency anemia, family history? And in appropriate tracking and helping the administrator team coordinate all that. In summary, what we can see from the data and synthesis of all the studies that we've got so far is that FIT is a very useful triage tool in the management of lower GI symptoms. And what is clear is that it has got far more detection rate and conversion into cancer detection than just using standard NG12 symptoms alone. But if we use FIT alone, that does come with a false sense of security. And we need to be aware of the limitations of FIT as well. So though we must move away from a symptom-based referral alone to FIT and symptom-based referral, clinical oversight of this does make all the difference in minimizing the false negatives and maximizing our cancer detection. We need to be aware of the limitations, trade-offs with thresholds and risk stratification in the context of our healthcare system capacity. And a key aspect of this is education and training resources so that we all understand why we're doing what we do. Thanks very much.
Thanks very much, Sunil. That was an excellent, really interesting talk. So I'm sure there are many questions, but as I said before, if we could pop them in the sidebar, we won't answer them in the sidebar, we'll take them at panel, but if you could just write anything that you'd like to ask any of our morning speakers, that would be great. And we'll move quickly on. We're a few minutes behind, but I'm sure you're finding it interesting. I'm delighted to introduce our next speaker, Dr. Kevin Monahan. So Dr. Monahan is a consultant gastroenterologist from St. Mark's in London, and he's also the chair of the BSG Colorectal Committee. And the Colorectal Committee are leading the development in conjunction with the ACPGBI of guidelines for the use of FIT in people with symptoms suspicious of colorectal cancer. So delighted that he's been able to come and talk to us today and very much looking forward to his talk. Thank you.
Thank you very much for inviting me to talk about the new UK guidelines for how we use FIT in a population of people who have symptoms where we suspect an underlying diagnosis of colorectal cancer. My name is Kevin Monahan. I'm a gastroenterologist at St. Mark's Hospital in London. This is a joint guideline between the Association of Coloproctology and the British Society of Gastroenterology, with co-chairs myself and Mike Davis, who's a colorectal surgeon that many of you will know, who works in Cardiff. And this group was established just over a year ago now to develop guidance as quickly as possible for the use of FIT in this population. And currently in the UK, FIT is being widely used. However, there's significant variation in how it's applied and how easily it's available to patients and in primary or secondary care. And therefore, it was felt that it was important that there should be some standardization in the approach, considering the best available evidence. And that's evidence that's rapidly accruing. And there have been some important studies that have been published over the last couple of years in this respect that we've incorporated. In parallel, there's a HTA process, which will lead probably to a next iteration of the guideline, or perhaps a guideline developed by NICE, which may incorporate more complex and sophisticated modelling methodologies. However, we feel that we have developed a guideline which is easily comprehensible, and will aid decision making in a very clear way, hopefully. We'll see what happens in the future. This is a 4-nation guideline, unlike NICE, and we've actually sought representation from the Republic of Ireland as well as the 4 nations of the United Kingdom as well. We've invited participation from the Royal College of General Practice. My personal feeling is that this guideline will only be successful if we have the buy-in and participation from primary care, as obviously this is a pathway which begins in primary care, and it's a key part of the decision-making process about who may or may not be referred perhaps into secondary care for further investigation on urgent cancer pathways. We've included patients with symptoms or signs of a suspected underlying diagnosis of colorectal cancer, but we have not considered in this guideline the use of FIT in surveillance, for example, in follow-up, or in screening or other asymptomatic populations. As I'm sure you're aware, NICE have in NG12 produced a guideline whereby if there's a 3% likelihood that a patient has cancer, they should be referred from primary care for urgent investigation. And this is sometimes called a PPV. And NICE developed what are arbitrarily termed high-risk symptoms, which have a low sensitivity for an underlying diagnosis of colorectal cancer, in fact, because individual symptoms do not accurately predict the likelihood of having colorectal cancer effectively. And this data below is is derived from the NICE guideline review, and the PPV is mostly less than the 3% threshold, which is what was deemed a necessary threshold for referral for urgent investigation in that guideline. If for using symptoms alone, then we're trying to recognize patterns in patients that are rather heterogeneous, and it's not an easy task in primary or secondary care. If we apply an objective measure, such as FIT, then we can much more effectively identify those patients who are likely to have an underlying diagnosis of cancer. With a threshold of 10 micrograms per gram of feces, the positive predictive value is over 16%. So 16% of patients who are referred after a FIT test which has a level of 10 or above. In the NICE FIT study, which was the largest published study, which we published in Gut about 1.5 years ago now, will have an underlying diagnosis of colorectal cancer. So it's a much more effective tool. There's excellent sensitivity. It may help to reduce unnecessary referrals for colonoscopy, because it has a low false positive rate, and it brings objectivity into an area that lacked this objectivity in scientific measurement previously. But we need to think about what the best threshold might be, and we've assessed that as part of this guideline process. There is in England, with the NG12 and DG30 NICE guidelines, there's an artificial divide, perhaps, which is developed between what are termed high or low risk bowel symptoms. But how does this actually translate into real world practice? In other countries, in Scotland, individual symptoms are recognised to be poor predictors of colorectal cancer. And in Scotland, FIT has been incorporated into the COVID pandemic response protocol. And I think they recognise that there's an element of clinical acumen that needs to be applied in determining who should be referred with symptoms. And that FIT is a really important adjunct to that clinical acumen. I think that GPs reasonably feel that they need to be backed up by having guidance in this respect. And although much practice has changed across the UK in how FIT is used, there is some apprehension or reticence from some who are concerned that actually much practice has changed without there being any published clinical guidance in this respect. If we think about this differentiation of high and low risk symptoms, patients who should be referred urgently or non-urgently. This is our data from the NICE FIT study. There are just over 7,000 patients who were referred with what were categorized as high-risk symptoms and almost 2,000 with low-risk symptoms. And whatever threshold is used, whatever concentration of fecal hemoglobin is used as a determinant of underlying colorectal cancer risk, there is no significant difference in the predictive ability of high or low risk symptoms to determine an underlying diagnosis of colorectal cancer. So the PPV is 16%, and in fact it's slightly higher in the low risk symptom population, interestingly. And I think this probably reflects the fact that many of these patients were still referred as urgent suspected cancer cases from primary care, and that it probably indicates that GPs were using clinical acumen in determining who was or was not referred. So in this guideline, we sought to establish a multidisciplinary group representing primary care and secondary care from relevant specialties, colorectal surgery, gastroenterology, but also biochemistry, radiology, clinical and nurse specialist. Also, we have an epidemiologist in our group, 2 lay members, patient representatives, and 2 research fellows. We also have a professional methodologist, Professor Joss Kleinen, who is a member of our group, who's been advising us throughout. We performed a systematic review of the available evidence, and we've used standard methodology to develop evidence statements, which have then been voted on through rounds of Delphi. We identified 3 key questions. Firstly, what pathways, how should the application of FIT be utilised in the clinical pathway from primary to secondary care? Should FIT be performed in primary or secondary care? And what safety netting mechanisms should be used for patients who have a FIT below the determined threshold, or what's sometimes called, perhaps inaccurately, a negative FIT test. We sought to identify what, in order to inform some of those decisions, what the diagnostic accuracy of FIT is, and therefore how it can be applied as a triage tool. And within that, within the whole population, we looked at subgroups, such as, for example, different types of symptoms, high or low risk symptoms, different age groups, etc. And it's also important that we determine the acceptability of the use of FIT in this population. And in fact, although there is significant data in, for example, screening populations of acceptability of FIT testing, there is very little data in this specific symptomatic population that's been published up until now. We also sought to identify lessons from implementation, because I think around the country, people are seeking advice about how they can apply this in clinical practice. Thanks to Brian Nicholson for this slide. He put together a group of tests that are commonly performed in primary care. And Brian Nicholson is a GP in Oxford. He, as per these examples, there are commonly performed tests which are often likely to miss a significant number of cancer diagnoses in clinical practice. And FIT performs significantly better than many of these. However, there will still be perhaps 10% of colorectal cancers that may be missed after a FIT test of 10 or greater. And therefore, we need to consider how we apply safety netting in this population. We developed a PICO, or a structure for how we would assess this within the guideline, thinking about different interventions that might or might not be applied in this population of people who have a FIT level of less than 10. We had a relatively short period of time in which to develop this guidance, and this created a significant amount of work and pressure over this time period. However, I think that we've developed something which is relatively straightforward, and I'll go through the outcome of the process in just a moment. As part of our Delphi, recognizing that there are a large number of stakeholders from across the country, we sought representation from different specialty groups, and we expanded beyond our 16 guideline committee group to invite 96 mostly clinicians from different specialties but also included patient and charity representation. The largest single group who contributed were from primary care. I'm pleased to say that there was overwhelming support for our recommendations through the Delphi process from primary care. We also had representation from 4 nations. And this is essentially a summary of the guideline. In patients or in adults from the age of 18 onwards who have symptoms of suspected colorectal cancer, they should undergo a FIT test in primary care. If the FIT test is 10 or greater, they should be referred for urgent investigation to secondary care. If the FIT test is less than 10, then we need to consider safety netting mechanisms. There is little or no evidence about what effective safety netting mechanisms might be, but I think that safety netting may be another expression that we perhaps use for clinical assessment and acumen in the absence of studies that demonstrate exactly what we should be doing in this population, and perhaps reflect current practice in that respect. Some patients who have a negative FIT test may be reassured by their GP where there is no other significant suspicion that they may have an underlying colorectal cancer diagnosis, for example, low risk PR bleeding in the younger patient. But there are some patients where a GP may still be concerned where, for example, they have persistent or unexplained symptoms, and they may still wish to refer the patient on an urgent pathway based on that clinical acumen and assessment. Or they may consider other pathways, for example, referral on a routine pathway. So who should be referred from primary care? Well, first of all, the number one recommendation that we've made is that no one should be excluded from primary care referral on the basis of a FIT test alone. It should not be a sole arbiter of referral. Secondly, we decided that a concentration of 10 micrograms was an appropriate concentration as a threshold for referral. And this is reflected in the algorithm. Thinking about safety netting, it was agreed across the Delphi process that some patients may be managed in primary care and not referred to secondary care, provided there is a process for safety netting in place. But if GPs have significant ongoing concern, then the patient should be referred to secondary care, of course, and that safety netting protocols should incorporate advice and strategies for how these patients should be managed. What's the diagnostic utility of FIT in this population? Well, we've recommended that FIT be used in any patient who has a symptom or sign. However, if a patient has an abdominal mass or a rectal mass which is palpable, they should be referred urgently, irrespective of the FIT test. Although the FIT test may guide subsequent investigation. With regard to subgroups, we felt that FIT testing, the evidence around FIT testing and iron deficiency anemia had accumulated significantly over the past year and a half, and that we felt that it was appropriate that patients with iron deficiency anemia should also have a FIT test, and that this would inform whether they needed to be referred urgently for a colorectal investigation. Patients with persistent PR bleeding who have a FIT below the threshold could be referred for a flexible sigmoidoscopy rather than a colonoscopy or a CT colonography. And in this guideline, we felt that we shouldn't discriminate against patients who are either very young or very old, or those with what have previously been termed low-risk symptoms, because these differences are perhaps rather artificial and not based on their likely underlying diagnosis of colorectal cancer, perhaps. And may in fact be discriminatory against some populations. This table has been produced as a table of trade-offs. If you use different thresholds of FIT, what are the consequences in terms of whether you decide that this patient needs to be referred for urgent investigation. Any test that we perform, there would be missed cancer diagnoses, whether it's FIT testing or direct colonoscopy or CT colonography. We also need to consider the number of colonoscopies that we perform. With the advent of the COVID pandemic, there was a 72% reduction in the diagnosis of colorectal cancer in the first few months after the pandemic started. waiting lists were already a significant problem, and we need to consider the whole population and what interventions we can offer the whole population, rather than perhaps over-investigating a smaller proportion of the population who are unlikely to have an underlying colorectal cancer diagnosis. A patient with a FIT level of less than 10 has a colorectal cancer risk if they have symptoms and a FIT level of less than 10, which is the same as someone who doesn't have any symptoms in the population at the same age. So essentially, you'd be offering an investigation to someone whose risk wouldn't necessarily be increased of having colorectal cancer with a FIT level of less than 10 who has symptoms. Well, of course, you may potentially miss colorectal cancer unless you're offering colonoscopy to everyone. We have to consider how we target our interventions at people who are more likely to have colorectal cancer than an average person. And when it comes to secondary care investigation, we believe that colonoscopy remains the gold standard, as it facilitates histological sampling of tumours at diagnosis. But CTC is also an excellent test for the diagnosis of colorectal cancer, although of course usually necessitates colonoscopy subsequently where cancer is identified or pulpectomy is required. But it's an excellent test to rule out a colorectal cancer diagnosis, in fact, and therefore an acceptable alternative in pathways, which can be determined locally. Finally, thinking about how we implement, and that there are gaps in what we know in terms of how this should be best employed. We've written an implementation section which will help with regard to the development of safety netting protocols around the country, pending better evidence becoming available, which will provide, we will perhaps be able to be more directive about what safety netting should entail. For example, we've signposted to existing pathways in areas where FIT testing has been relatively successfully implemented, including in Scotland and Nottingham. We want to develop guidance for commissioners, ways that we can measure the performance of the guideline and its impact on patients. And as I said, there are gaps in our knowledge, and therefore we've prioritised research questions, which will allow us to develop a better guideline in the next few years. But hopefully this guideline will be useful and will improve access to patients for patients to FIT testing, and may in fact improve their access to secondary care investigation. I think that for example, in patients who were considered to have low risk symptoms previously, we have more objective measurement of which amongst those patients are likely to have an underlying colorectal cancer diagnosis, where perhaps it was quite difficult for them to access secondary care in investigation. This should be better facilitated through the application of FIT. So thank you very much. I'm in the middle of a colonoscopy list right now, although it doesn't look like I am. And hopefully I'll be able to take some questions if I can call in between colonoscopies. And yeah, thank you very much otherwise, and please do get in touch with me if you wanted to discuss any aspect of the guideline. I'm more than happy to, and I recognise that any such guideline is not perfect, and would like to hear from people who have different views on how this could be implemented.
Well, thanks very much, Dr. Monahan, and thank you so much for squeezing us into your really busy schedule. But very interesting talk, and hopefully you'll be able to join us shortly for a panel discussion. So we're running a few minutes over, so I'm going to hand over now to Dr. Sunil Dolwani, who's going to chair the panel session. So you've still got a few more minutes to be able to write your questions in the sidebar, and hopefully most of our afternoon speakers will be able to join us on the panel. Thank you, Sunil.
Thanks, Hayley. I think it would be helpful if the panelists could please put their cameras on as well. And I thought that was quite an interesting discussion in this first session. And I wonder what people feel. particularly for this kind of event where we're going to be hearing from all health boards about perhaps the slightly different ways they've done this, is there an appetite for there to be some standardization of safety netting, some even broad guidance around it, or do people feel that this is very specific to their own processes and setting, and that would be not helpful? It just would be nice to hear some views on how we feel safety netting might be implemented, and if it can be organization specific or more via national Welsh. I don't know if any of my colleagues would like to comment on that. Rachel, how do you feel about the primary care setting for safety netting here?
Yeah, no, I think from a primary care perspective, it would really be very good to have national guidelines. So, you know, it's countrywide, and obviously in primary care, we're quite well placed with our council lead GPs to disseminate that. But yeah, I think national would be good.
Mike, what about secondary care? Do you think that we often have a lot of discussion, robust discussion, even between gastroenterology, colorectal surgery? Is there, do you think, a reasonable space there for us to try and harmonize processes and safety netting so that it doesn't seem to vary between where the referral is sent?
Yeah, I think there is a need for that, and I think patients deserve that. I mean, even within some of the large, you know, geographically variant health boards in Wales, there can be quite different management between individual sites within the same health board. I think in secondary care, obviously there are differences in the resources available. So certainly in North Wales, and especially in Wrexham, where I'm based, we don't have a FIT coordinator, a nurse coordinator who could track and do some of the patient contact and things that would particularly be helpful with safety netting. But I think that what would be nice would be for to aim for something like a single point of access for all lower GI referrals, whether they be gastro or colorectal, try and remove a little bit of that grey area that primary care often struggle with knowing who the best person to refer to. Just have a central point of access, and then a trained individual following a pathway, directing that referral as appropriate, and ensuring that common pathways are followed. I think that would reduce variance. It's better for patients. Probably enable some harmonisation of waiting lists. It would avoid some of the individual variance you get between individual clinicians. So even utilising some of the pathways that we currently do, you'll find huge variation between individuals in terms of how aggressive or not patients are investigated for exactly the same symptoms. So you'll have individual clinicians who may just arrange for a patient to have a one-off secondary care investigation and then refer back to primary care. And you'll have another clinician faced with a patient with identical presentation who may, really investigate that patient to the hilt and use a lot of resources, perhaps without much clinical gain, and perhaps to the detriment of others who are waiting. So, I would agree in principle, some guidance that we can all follow would be really, really helpful, in short.
Thank you. Rachel?
Yeah, just to back up that, I completely agree. I think we need a single point of access for GI symptoms. It is, from a primary care perspective, it can be quite confusing where the patient should go, and that can exactly lead to differences in the way they're treated. I did a quick spot check of a few GPs, and they all seem to refer to the different specialties with the same symptoms. So I think there is confusion in primary care, and if we can standardise this, it will really help the referral process.
I think that's a really good point. But what strikes me, and I'll bring Raji in a minute, because Raji, you've got actual experience of how we juggled this in Cardiff and Vale, but it strikes me that it's likely this is going to be a combination of, ideally, IT and informatics doing a lot of this harmonization, but until we get to that point, it's likely to be very manual. Raji, what do you think?
I definitely think it does need to be standardized, and I echo both Michael and Rachel's views on having a single point of contact for GPs. I think at the moment, the lower GI pathways sort of, some of them go to gastro and some of them go to surgery, and it's kind of, it is confusing. And I think a single point of referral would help. And also, we obviously had a FIT coordinator and a FIT nurse, which certainly helped. But our resources were still very, very tight because the coordinator's role was only a part-time role. The nurse was only a part-time role. So these are large data sets that come through. When the type of data that we get through the electronic referrals from primary care is through the WPRS system, and that data can be captured centrally. So we are, and in addition to that, the online requests for FIT has also been captured centrally. So we have a great opportunity here where we can actually visualize data centrally. Prior to this, I think it was more so, handwritten referrals or referrals that went through and data was not visible. So hence we never knew about variation of practice. So I think, yes, managing data, having resources to manage that is key. I also wonder standardization of the letters that go out for safety netting, whether it needs to, we did have letters that went out, but perhaps in hindsight, I think perhaps those letters need to be a bit more detailed, whether they are standard template letters or whether they're individualized as per what the clinician thinks. That's up for discussion, really.
That's very helpful. I guess it's a balance to strike between being too prescriptive and losing it, just making it too protocolized versus making sure we're addressing the individual patient and using some clinical input into that. But that's a useful take-home message as well for us to try and look at. Dana, you wanted to come in?
It was just to reiterate, really, I think really good points made, and obviously from a pathways perspective and the flow for the patient and communication and all of that, I think it's key that we take forward the conversations about, the nurse that supported you, the administrations, and evidently the IT, which I'm sure will come up when we talk to the labs and things. But I also, I think I heard a talk from one of the Scottish team up many years ago where they actually centralised their referrals for GI and surgery back then as they introduced FIT. And I think that was one of their, their learning points back then. So something I think we need to think about.
Thank you. Yes, I agree. I think that is certainly something we can do something about and try and pull together a lot of the learning and the communication elements of it. Raji, you wanted to come back?
Not to labor the point really, but I do think that these data sets are extremely complex. And in addition to obviously a coordinator, a nurse that helps to support this, I do think that somebody with a project management type of role needs to support. I know resources are very small in the NHS, but I think these are really important data sets that can actually make a difference. So people with, who can, the types of spreadsheets, I've got spreadsheets coming out of my ears because I've merged literally about 100 spreadsheets, but I feel that that's a role, that's something that a project management or an IT person or something like that should also be incorporated into that.
Yeah, I think the point is well made, Raji, and what if we have time, we could discuss this much further, because there is a direction of travel of using business intelligence, using the intelligence from the data that we collect, which is not done particularly well in our health boards. I suspect it might be a more efficient design to again try and harmonize some of that, taking one thing at a time rather than trying to swallow the whole thing together, which is a very big beast to tackle. FIT lends itself to a project that might be harmonized across Wales using the data that we collect, and we'll talk to our demand and capacity group and the delivery unit colleagues to see if there is something that they might be able to help with. But just from experience, that is something that is going to need a fair bit of effort to do. I just want to bring in one more quick question and perhaps comments from the audience on this before we close this panel discussion, which is, you would have seen a lot of the evidence from the pilot that was presented, the national data, international data, Kevin's presentation, what I mentioned about rectal bleeding and how we manage it. And there's an increasing level of comfort around and confidence around using FIT in rectal bleeding patients requesting a flexi-sig. And if that's positive, upgrading to colonoscopy. If it's not, you still carry on and do a flexible sigmoidoscopy. That seems to be a very good safety netting process. Do people feel that is a reasonable place to actually harmonize the setting across Wales, or are there still some concerns around that approach? Mike, I'll start with you. What do you think?
I'm very comfortable with that. I think that the subgroup analysis from the NICE FIT study would support that as well. The cancer detection rate in FIT negative patients with rectal bleeding does remain low, but the majority of those are going to be identified on flexible sigmoidoscopy. And I think, going back to your presentation, Sunil, we're working in a capacity limited, environment, and we have to accept, yes, that what's best for the patient in front of us, but we do have a responsibility to address the wider context of limited resource and the pressures that we're under. And I think that if we sent every rectal bleed patient for colonoscopy, not only are we going to be utilizing a huge amount of extra capacity, some patients will come to harm as a result of undergoing colonoscopy, that it's not without risk. And I think that there's an absence, a lack of benefit or evidence showing benefit for that approach. So I would advocate, if they've got NG12, if they meet the, going back to NICE criteria, which we know aren't great, but I think if they're NG12 with rectal bleeding, a USC flexible sigmoidoscopy, if they're FIT negative, if they are I guess a lower risk referral, a younger patient with anorectal bleeding, then a non-USC flexible sigmoidoscopy is a very good safety net.
That's interesting, and I think certainly consistent with the general view. I'm not hearing much dissension in the chat, but I think there's a lot of agreement around John Green's point, which is very valid, around frailty, appropriate use of FIT in elderly frail patients. Rachel, I fully agree with what you've said, and others as well. I think that is at the start point, really, where an individualized clinical approach is far more appropriate than an automatic protocolized approach, particularly in that setting. So I think there's wide agreement for that. There's an interesting question just before we close that is around, do people actually accept referrals without FIT? Now, I think what certainly I remember from the Cardiff and Vale pilot is we've accepted them, done them on behalf of the primary care colleague, but sent a reminder to say, please remember that this is available now and then you should do it, rather than having a draconian policy of not accepting it. I don't know if others have done differently. It'd be interesting to hear that very quickly in the next couple of minutes. Have others been much more strict in terms of their policy to accept referrals without FIT? We've got other colleagues amongst the presenters. I wonder if perhaps we could quickly hear from Ruth and Mary about what their approach has been. Dana, you wanted to come in?
Yeah, I was just conscious of time, Sunil, and obviously we were due to break now and we've only got a couple of minutes left, but we have obviously got a great panel, and I think all of us can join that panel in maybe session 2 Q&A.
We will. Let's just hear about this one and then we'll close. Yes, sorry. Ruth?
Well, in Paris, we use a number of different providers, and it varies between the different providers, particularly across in the English border. So currently, Shrewsbury and Telford hospitals don't require a FIT test with USC referrals, whereas Wye Valley Trust, it's mandatory and they don't accept referrals without a FIT result. And then down in Aneurin Bevan, my understanding, though Mary may correct me, is that currently that we're requested to do a FIT test at the same time as we do the USC referral. But it does vary according to our providers around our borders. Okay,
I think that's a helpful and interesting input. I think a suggestion that we'd make is we've got far better engagement through having a supportive approach with an educational reminder rather than trying to be draconian about it. And perhaps that might be considered by colleagues when they're implementing this in their own patch. So thank you all for a really interesting discussion. It's been a really good first session.